Good evening, doctors. Today I was thinking about reading the pneumothorax guideline from the Green Book. So let's start. Bismillah ar-Rahman ar-Rahim. The pneumothorax guidelines. How you can recognize the pneumothorax and assess it. First of all, you have to recognize whether it's tension pneumothorax or just a simple spontaneous pneumothorax. So the tension pneumothorax, which is very rare, but it can happen, characterized by severe dyspnea, which is severe difficulty in breathing, circulatory compromise, trachea plus minus apex speed displacement, hyper-resonant percussion note on the affected side, absent or decreased breath sounds on affected side as well. So these are the main features of the tension pneumothorax. The most important feature, that's the shifting of the mediastinum to the contralateral side, which is you will find the trachea and the apex speed displaced a little bit. So in this situation, you have to treat immediately. If not fully trained, you get help from your senior. First of all, you will give oxygen 15 liters per minute with mask, with reservoir bag. Insert a large bore cannula 14 or 16 giga, which is about 4.5 centimeter or more in length, into the second anterior intercostal space, whether the right side or left side, according to your clinical finding. In the mid-clavicular line, insert chest drain mid-axillary line in the fifth intercostal space. Remove emergency cannula when bubbling in underwater seal system. Confirm intercostal tube system functioning. So once you see the bubbling in the underwater seal system, you can remove the emergency cannula that you have inserted in the first place. Also the bubbling, that means the intercostal tube is functioning and it's not blocked. So what about the spontaneous pneumothorax? Symptoms may be very minimal. It's the opposite to the tension pneumothorax. Sudden onset, occasionally at rest. Chest pain usually will be only on one side, unilateral. There is a dyspnea, resonance on percussion with reduced vocal fremitus and breath sound if moderate to large. Okay, so what investigation you would do in this situation? You will need to do the postero-antero chest X-ray, BA chest X-ray. If findings are unclear on BA, lateral, if possible, lateral decubitus film may help. So if you did not find any finding in the BA view, you do the lateral decubitus chest X-ray. If findings obscured by surgical emphysema or complex polydisease, CT scan may help. So if there was a surgical emphysema or there's multiple poly hiding your finding, so in this situation you will order CT after consultation. Be aware, suspected basal pneumothorax usually implies a poly. CT scan will differentiate poly from pneumothorax. So in here you will have differential diagnosis when you have spontaneous pneumothorax. So it could be a poly, but you cannot poly, which is a large bubble of water of air. So in this situation, you will need to do CT scan to differentiate whether this is a poly or a pneumothorax, in fact. Okay, next page, we have the diagram of the, which is summarizing the immediate treatment of pneumothorax. First of all, you will have to assess You will do a chest X-ray, will show 2 centimeter or more rim of air. If yes, you probably suspecting chronic lung disease. If yes, you will insert intercostal tube drench. Okay, so now we will pick no in here. If you have done a chest X-ray and this is shows 2 centimeter or more rim of water, there's no rim of air on the X-ray, but still there is a significant dyspnea. If yes, you will do aspiration. If no, there is no significant dyspnea and you have chronic lung disease, you will prescribe high flow oxygen and observe for 24 hours. If no, you don't have chronic lung disease, you will observe for only 4 hours and follow up in 2 to 4 weeks. Okay, so on here, if there is a rim of air more than 2 centimeter and there's chronic lung disease, we have picked already yes. Now we're gonna pick a no. You have a rim of air, but there is no any underlying lung diseases or any chronicity of lung diseases. No, you will aspirate as long as you have a rim of air. If the aspiration was successful and asymptomatic, yes, this is a chronic lung, and there is a chronic lung disease. So after that, you will prescribe a high flow oxygen and you will observe for 24 hours. If there is no chronic lung disease in here, and you already aspirated the rim of air, so you will observe only for 4 hours after aspiration. No need for intercostal tube in here. And you will follow up him in 2 to 4 weeks time. Okay, this diagram is simplifying the steps for us, and it's straightforward. About the aspiration, aspirate with cannula as above, suction and not routinely required for chest drain. Discuss all with respiratory pediatrician within 24 hours. So of course you will not do all this by yourself. You will involve the respiratory pediatrician with you in here, your senior. The other diagram in here, talking about the management of intercostal drain. Once you have inserted the intercostal drain, you will have to manage it and check it from time to time. So first of all, you will assess the patient. You will assess the patient situation and clinical examination. You will order chest X-ray next morning after you have inserted the intercostal tube. So that's chest X-ray next morning. If you have fine re-expansion of the lung, yes, still bubbling, we will go yes now. So you have found re-expansion and the system still bubbling, yes. So you will go for respiratory opinion for your next step. If you don't have a re-expansion yet, still bubbling or swinging or surgical emphysema, yes, you will check respiratory opinion. If no, there is no bubbling or swinging or surgical emphysema, check drain and underwater seal. Okay. Okay, if there is no bubbling after 24 hours, remove the drain, repeat chest X-ray, collapsed again, yes, you will ask for respiratory opinion. If there is no collapse, you will follow up with him. Okay, so the bubbling of the underwater seal system is very important in here, and it's the step which is going to direct you for your next step. So, and chest X-ray as well next morning is very important. If you have found the re-expansion of the lung, that's good. and underwater seal is bubbling, so that means the tube is working and everything is going fine. If there is no bubbling after 24 hours, you will remove the drain, do chest X-ray again, and check whether there's a collapse or not. So this diagram is very nice and clear. There's some explanation in here. Let's read it together. About the chest X-ray, keep underwater seal below level of chest at all times. Remove of chest drain, bubbling stopped for at least 24 hours. Cut drain, securing suture with the draw tube while patient blows out through a straw. So this is the technique how you can, when you are going to remove the chest drain, if there is no bubbling after 24 hours, you ask the patient to blow out while you are withdrawing the tube. Close wound with steri strips. Check drain. If lung not reinflated and no bubbling in underwater bottle, try to remove the block or kink. If unsuccessfully, remove drain, insert a new drain through clean incision. Respiratory pediatrician's opinion. Of course, you'll involve your senior in every step you do in this situation. It's not your job. You can't do all this by yourself or take decisions by yourself, as you are going to be only registrar. So, so the respiratory opinion, respiratory pediatrician opinion in here, if no re-expansion, consider air leak. So that's mean there's some air leaking somewhere, displaced or blocked tube, bronchopleural fistula somewhere, underlying pulmonary disease. So you have to think of all this stuff. Use high volume or low pressure suction, 1 to 2 kilopascal per bar. That is 8 to 60 millimeter mercury, 8 to 20 centimeter water. If altitude chest drain system, use it. Sit wall suction 260. So that's the parameters of the system itself. You don't need to know every single detail about it. You are not going to be asked about all these details in the exam. Early thoracic surgery refer when pneumothorax fails to resolve after 5 days. So when are you going to call or ring the thoracic surgery or cardiothoracic surgeon if there is no any improvement after 5 days, or there is no any obvious resolving or improving in the pneumothorax for 5 days? So you will ring and call the thoracic surgeon in here. Management or after 3 days if patient has chronic lung disease. So in healthy patient having a pneumothorax not resolving for 5 days, or with a patient underlying chronic lung disease within 3 days with no improvement. So that's the only indications for involving the thoracic surgeon in here to do surgical intervention in here. About the follow-up in 7 to 10 days, then with the respiratory pediatrician. So you will bring him for follow-up again in 7 to 10 days after discharge. Patient given discharge letter with written advice to return immediately if it deteriorates. So you have to make sure he got this written letter with him or with her on discharge. No air travel for 6 weeks, and chest X-ray changes resolved. So this is the second golden advice in here. So you advise your patient not allowed to travel, no air travel at all for 6 weeks. For 6 weeks after the after discharge, and this is very important to mention that. So that's the pneumothorax guidelines, doctors. I wish you enjoy it, you get benefit from it. Thank you for watching. Bye bye.